So, hi everyone, welcome to the research meetup we organized here at PathCheck along with our lab and the other collaborators out here. And thanks a lot for the speakers joining us, Professor Jonathan Berman, Professor Rahul Siddharthan. Thanks a lot for sparing your time with us. And without much ado, I'd like to hand over to Christian to introduce our speakers today. And yeah, let's get the talk started.
Hi, good morning. It's my pleasure to introduce my friend, Dr. Jonathan Berman, who's an assistant professor of basic sciences at the New York Institute of Technology. His primary research interests are in the molecular origins of hypertension and regulators of ion channels, and is currently studying SARS-CoV-2 in his lab. But how I know him is from 2017 in the DC March for Science. He was the person that originally organized that march and was a national co-chair. And recently he wrote a book that was published in MIT Press 2020, which he didn't know at the time was going to end up being a pandemic. So it was kind of interesting coincidence and timing. So his book is on anti-vaxxers, how to challenge a misinformed movement. And without further ado, I will let him speak.
Oh, well, hi, everyone. Thank you for the introduction. So I won't repeat too much of the introduction, but yes, I am Dr. Jonathan Berman. Nice to meet all of you. And so I'm going to treat this as sort of a quick update on where we are with anti-vaxxers in the pandemic. So this is a group that's been around for a long time. Spent about 2 years writing a book about them. It came out last year. Here's the March for Science. This was one of the largest science advocacy events in science education events in history. So there I am. Everyone else is really short. But so that's the front of the March for Science. So what is the problem with the anti-vaccine movement that we should even care about it? Yeah, if enough people are going to be vaccinated, then it's not really a problem. So looking at the numbers, most people do agree that vaccination is important. And these are older numbers, but this hasn't changed too much. So majority of the world agrees vaccination is important. Vaccines are important for children to have. And however, people do tend to underestimate the degree of vaccination that occurs. About 85% of the world's children are vaccinated for measles, but most people estimate far less than that, 20%, 50%. The correct answer is 85%. So most people who have access to vaccination do choose to be vaccinated. Within the United States, it's even higher. So mean is about 95% of children are vaccinated for DPT. So that's another early childhood vaccination, just as an indicator of coverage. And this color coding indicates different exemptions that are allowed. And so allowing these exemptions or not doesn't make a huge impact on where states fall on this graph. And we've seen that vaccination has been very successful in the last decade. So using measles again as an example, the vaccine coverage on the x-axis and measles cases over the per million people. Over time, coverage has increased worldwide to greater than 80%, and the number of cases has reduced from almost 900 million cases, almost 900 cases per million people to now fewer than 100 cases per million people. So our vaccination programs worldwide have been historically pretty successful. Now, dealing with coronavirus, there was a lot of concern late last year, that there would not be sufficient interest in vaccination because surveys were being performed and less than 50% of people were saying, yes, I definitely will be vaccinated when the vaccine is available. And we can see over time that's changed. So over time, the cumulative people who, yes, want to be vaccinated or have been vaccinated is now at 70%. The number of people who are unsure has declined from about 30% to about 7%, again in the United States. And then the number of refusals has stayed relatively level. So level refusals is what we're concerned about. And I'll explain a bit about why, but demographically, so in the past, vaccine refusal, vaccine hesitancy has been relatively nonpartisan. There was no strong difference between political groups. In the last year, that has changed. So this is data from a couple of days ago, April 19th. The biggest difference right now in vaccine refusal is political affiliation. So conservatives, among white Republicans, almost 45% refusing vaccination. Among Black Republicans, almost 35%. Among white Democrats, only about 2%, and among Black Democrats, only about 8%. So along racial lines, but especially along political lines, there are now disparities in vaccine acceptance. So that 25% of the population should be worried about it. So one way to get at that is to look at herd immunity threshold. So that's the mathematical point at which there is no net increase or decrease in the number of new cases in the population. And that's calculated as 1 minus 1 over R naught. So R naught being the average number of new cases from a given case of the disease. And we've had a variety of estimates of what R naught is, but it's likely somewhere in here between 1.5 and a little more than 3. And this is just a curve that you can calculate from that equation. And so what fraction of the population would need to be immune, either through prior infection or vaccination, in order to have no net new cases in a well-mixed population that isn't implementing other measures such as mask wearing, social distancing. If this is the right number, and it's probably not, then we're kind of already there, right? Because now about 40% of the US population has received at least one vaccine. And if the real number is 3 for R naught, then that seems doable. We could maybe keep vaccinating everyone who wants to be vaccinated and get there. But there are caveats and concerns that we need to consider. So immunity comes from both prior infection and from vaccination. That's something Kristen likes to point out. People tend to ignore the prior infection. And vaccine-induced immunity may be stronger, may not. We don't really know very well yet. And then these new variants that are being described, they kind of have two hits. They seem to escape immunity from prior infection, and they may make vaccines less effective. So a vaccine that's 95% effective with current prevalent variant may only be 70%, 50% effective with a new variant. So if a new variant has an R naught of 2, but vaccination becomes only 70% effective, then you need 71% of the population vaccinated to reach the herd immunity threshold, compared to a theoretical 50% with a 100% effective vaccine. So the question is, when do we reach this point when the number of vaccines available exceed the number of people who want the vaccine? And if our herd immunity threshold with the new variants and whatever mix of mask wearing protocols and lockdown protocols are, if that's still around 25%, then we're cutting it really close. Then we need to work on finding ways to persuade people who are current refusers to become vaccinated. Because if it turns out we need 80 or 85%, and we have 25% refusal rate, then we're potentially in trouble. Another area of concern: young people are less likely to accept vaccination, childhood vaccination, than older people. Usually these are people around the time they're having their first child. That should be a concern for the younger population once vaccination starts occurring there. And an important point I like to make is that a lot of this vaccine refusal is cultural, religious, linguistic. It's how people's culture interacts with the way the vaccines are marketed and brought into the market, and not necessarily people who are just against vaccines for the sake of being against vaccines. So an example I like to give, these are two vaccines that were introduced for viruses that can potentially cause cancer and which are sexually transmitted. Hepatitis B vaccine was introduced in the 90s and was added to routine childhood vaccination schedules without much fanfare. Gardasil was introduced a bit after that, but it caused a large uproar, and especially among the US religious right. And the difference was that Merck, producing Gardasil, went to state legislatures and lobbied them to add it to childhood vaccination schedules, but only for girls. And these religious organizations saw that as losing a potential punishment for premarital sex. They have their religious interest in controlling the sex lives of young women, and so they saw this as encouraging something they were against. And so this has caused an uproar and anti-vaccine misinformation, specifically about this vaccine, but not this vaccine. So I want to distinguish briefly three groups: people who are anti-vaccine, vaccine hesitant, and under-vaccinated. The majority of people in most cases who aren't vaccinated are under-vaccinated. So they want to be vaccinated, or they would, but they don't have access, they don't have health care, they don't have funds, they don't have time off from work to go get vaccinated. It's too inconvenient for them. So the challenge with them, and probably the biggest logistical problem, is getting them to the vaccine site or getting the vaccine site to them. The vaccine hesitant are people who don't know, they don't have enough information, they still want time, they still want to look into things before they choose. So that's the unsure in that earlier graph. And then anti-vaccine, so people who have staked out an ideological position that vaccines are bad and they don't want to be vaccinated at all. And a lot of the rhetoric around, or the writing, the reporting on the anti-vaccine movement reports on it as if it is a new phenomenon, and it is not. So I want to do a very brief touch on the history. I don't know how much time I have. I was told about 25 minutes. So I have, I think, about 9 minutes left. So I'll be quick. Touch on the history. So smallpox was a disease that was eliminated by vaccination. And for much of recent human history, it was a scourge that killed about 10% of all people. There are smallpox scars on mummified remains found from ancient Egypt. So this has been around for a long time. And there was an observation made in the late 1700s that milkmaids who were milking cows often would not be able to get smallpox, but they would get cowpox. So this is what a cowpox pustule looks like. It looks similar to a smallpox pustule, but fewer of them, and it doesn't have the associated respiratory problems that can come with a smallpox infection. So this observation was made a few different times in history. One of the first people was this person, Benjamin Jesty, and he observed this and decided to test it out when there was a smallpox outbreak in his hometown. He took a knitting needle, he popped a pustule from cowpox, and he scratched his wife and children with that knitting needle. And then his neighbors became the first ever anti-vaxxers because they said, "What is wrong with you?" That's a ridiculous thing to do. And at the time it was, because it wasn't a systematically arrived at piece of knowledge. He was just trying things out. First person to systematically study vaccination was Edward Jenner. So he conducted a kind of a mini study, taking lancets and taking cowpox pustules, taking the lymph from the pustule and scratching children with it, and then attempting to inoculate them with smallpox and seeing they didn't develop the normal smallpox-like symptoms. So that was initially rejected by the Royal Society and by others. And he had self-published. He went to the court and he convinced aristocrats who saw how potentially great it was, and so it started to spread, and almost immediately there was backlash. So this is a political cartoon from the time showing cows bursting forth from people. So people believed that vaccination could pollute your body with this cow matter and turn you into a beast, give you horns, make cows erupt from your skin, which it turns out that does not happen. You do not erupt forth with cows when you're vaccinated. Another political cartoon from the time: vaccination against smallpox, or mercenaries and merchant mischief spreaders of death, devastation driven out of society. So there were a lot of people who did not see the value of this technology. Nonetheless, and this is data from contemporary death records, after vaccination is introduced, smallpox deaths almost disappear. So in this period, however, a lot of people come to oppose vaccination. There is an anti-vaccination league. There are marches. In Leicester, there were 100,000 people who marched against vaccination. In Brazil, there was an anti-vaccine revolt. People marched on the Capitol. This is a paper I published a few days ago, April 6th, about anti-vaccine riot in 1885 in Montreal. And the reviewers were asking, well, why, who cares? This is 100-something years ago, long time ago, and it's not going to happen. Then five days later, we have another anti-public health protest that turns violent in Montreal. And my only point there is that if we look at the past of these things, then we can learn something about what's happening right now, where people are coming from, and the reasons that they oppose vaccination and public health measures. So in the 20th century, Gandhi was against vaccination, and in part because it was seen as an outside colonial power imposing this technology. And then in the 1950s, a famous incident made people very skeptical of vaccines once again. This is Jonas Salk developing the Salk polio vaccine, which was an inactivated virus vaccine. So poliovirus was treated with formalin, and then that inactivated it so it couldn't cause infections, but there was a large batch that was improperly inactivated by Cutter and Wyeth labs. And that resulted in about 200 cases of paralysis. So people became aware that there were actual problems that could occur in the production of vaccines. Excuse me. Then in the 1970s, a few years later, this paper came out, Neurological Complications of Pertussis Inoculation. And it turned out that the neurological problems they observed weren't real. So this was a spurious result. But what happened was a number of countries ended up suspending their pertussis vaccination programs and ended up with outbreaks of pertussis that resulted in dozens of dead children. So this idea of danger, this flag was raised, which not improperly necessarily, but the results were death. And then in the United States, programs aired like this, Vaccine Roulette, so claiming that vaccination with DPT, this combined vaccine, was dangerous. And after that, a series of lawsuits were filed that almost prevented vaccine production from being performed at all. So many companies were deciding it was too dangerous to produce vaccines because of lawsuits that it threatened the vaccine supply. So Congress created what was called the Vaccine Court. So this was a program so that if someone believes they have been legitimately injured by a vaccine, they can, instead of suing the company out of existence, they can be remediated by the United States government. So that's the system we have now. A lot of anti-vaxxers will complain that you can't sue vaccine manufacturers, and this is the reason. So then in 1998, this guy, Andrew Wakefield, published this paper, which was retracted in 2010, claiming a link between vaccines and autism. And it came out that he had been paid by a lawyer to do this in preparation for a lawsuit, and he had falsified a lot of data, and much treasure and time and careers have been spent now looking for this link to try and find it. No such link has been found. And so for the past 20 years, this was a big part of anti-vaccine rhetoric, this claimed link. So when we see science denial, there's some recognizable features of it. The use of fake experts, logical fallacies, moving goalposts, cherry picking, and conspiracy theories. So we've already seen these with anti-vaccine movement in response to the coronavirus vaccine. We've seen conspiracy theories. Bill Gates is trying to track us with microchips, I guess. We've seen fake experts brought out to advance treatments that have been shown now not to be effective, like hydroxychloroquine. It's got what plants crave. And we've seen cherry picking. So looking at specific studies without the larger context of the field. So for example, the Danish mask study, taking that, but not taking any of the other literature on mask wearing. And that can go the opposite way of ignoring studies just because they go against the larger trend. So we've seen all of these features of science denial. Once what seems to happen is people go through a process of what I would call escalation of commitment. So they're exposed to anti-vaccine ideas. I'm getting close to time, so if I'm running over, just flag me, I guess. They go on Twitter and they make anti-vaccine friends, and so they're rewarded for sharing memes or tweeting things that are anti-vaccination. They join groups on Facebook, and those groups become increasingly polarized over time, both because of that escalation of commitment and because less extreme members of those groups leave over time, leaving only the most extreme members. So to quickly put a face on anti-vaccine movement and say, let's talk about two hypothetical models, not to create a straw man, but to give us someone to talk about. So let's call them anti-vaccine parents. Let's call them Jim and Jenny. And they live in Measleton, Michigan, where the population is declining, and they're new parents, and they go on their Facebook group, Measleton Moms, and they see Dizzy Vector says, went to my pediatrician and they wanted to vaccinate my baby. I said, no, I don't want them injecting toxins into my baby. And so someone else chimes in, my daughter is vaccine injured. After she got MMR shot, she had fever for 3 days and then had seizures. And so this is concerning, right? This is what parents are supposed to do, is look for threats to their children and protect them from those threats. So they go online. Jim goes to his favorite news source, InfoWars. COVID vaccine, what else could they put in the shot? There is no doubt that nanotechnology is indeed very much involved in cutting edge vaccine research. And then Jenny goes on Amazon, and the first 6 things that pop up are there anti-vaccine books, shirts claiming various chemicals that sound scary are in vaccines. So these appeal to different aspects of what's called moral foundations. So this is a theory that's been developed to explain how more liberal and more conservative people respond to different arguments. Conservative people tend to respond more to arguments about liberty, loyalty, authority, or sanctity. So maybe Jim responds to arguments about government overreach or about the impurity of putting vaccines into your body. And maybe Jenny responds more to stories about children being harmed, anecdotes about seizures, and so forth. And so when it's time for the wellness visit or the vaccination with the pediatrician, Dr. Smith says, it's time for your baby's vaccine. Jenny is having none of it, and she says, I've done my research. And in fact, she has. She's done a lot of research, and she's read a lot. She has a lot of information. It's bad information. She's not being appropriately selective with her sources. So what changes minds? Well, the best thing to do is prevent people from going down this route in the first place. So if someone at some point had given nudges in the other direction, had posted their vaccine card and said how excited they were to be vaccinated, or had given them other information, direct them to better resources early on, they might not have gone down that path. Stories about people who change from being a part of the anti-vaccine movement to being pro-vaccination, they almost always are people who have been nudged and then decide to give the other side a shot, to listen to what they have to say. And they go do reading. They read a book such as Paul Offit's book, and that is enough. That searching out new information on their own is what convinces them. So what we can do is create safe environments for people to change their own minds. So non-judgmental environments, listen to what they have to say, and help nudge them toward considering other points of view. That's about all I have.
Thank you very much. So I think we're gonna, I definitely have questions, and I'm sure other people do too, but I think we're gonna wait till the end of the next talk and have them all at once. So I'm gonna go ahead and introduce our next speaker. So Dr. Rahul Siddharthan is a member of the Computational Biology Group at the Institute of Mathematical Sciences in Chennai, India. His main interests are regulatory genomics, chromatin, chromosomes, centromeres, evolution, and next generation sequencing. We originally know him from a paper that he published in 2020 on risk assessment and contact tracing for epidemiological intervention. And without further ado, I will speak.
Sorry, that was my phone that I forgot about. Yeah, okay, thanks very much. I hope my slides are visible. So thanks, Christine, and thanks everybody, including Tav in absentia. So as Christine said in her introduction, my main interest is in computational molecular biology, and I have not really done any epidemiological work as such, but I'm a part of a group where there are other people who are very actively in epidemiological modeling for a while now. So I knew what the SIR, SEIR model family is and so on. And also I have a background in physics. So from the dynamical systems point of view, it's interesting. So the background for this talk, this is not published, it's still on medRxiv. But it came about at the time the pandemic was peaking, like in March or April last year. And so there was a lot of discussion about contact tracing apps at that time. So this is, some of us started discussing, can we do it a bit better while also keeping into account privacy, confidentiality, and basically, so I'll come to that, but Vishwesha Guttal and Sandeep Krishna were my collaborators here, and we put out this preprint fairly fast, but the pandemic moved even faster. And though we talked about it, I think I personally kind of felt it was not relevant anymore, but recently we've started talking about it again, that at least as a piece of methodology, we should try to publish it and maybe see what the shortcomings are given what we know and so on. So this is the idea. Contact tracing, so from what Rohan said, you are still very much interested in it. The idea was to use mobile phones to trace contacts, and around the time, I think before we even put out this preprint, the Indian government developed an app called Arogya Setu that does that, and governments around the world did the same thing, or private organizations. Apple and Google had an API to do it for Apple and Android phones. But basically the idea being, if two people both have their Bluetooth on, the phones can detect each other, and then you can tell whether they've been in contact. So what we, by the way, if you can tell me 5 minutes before my time, that would be helpful. So we thought, can we do better? So most implementations basically do this, that I get infected, I get test positive, then this app will see who I've been in contact with, and that's the alert to those people. But what about if A met B and B met C? Isn't C at risk too? And can we take account of that? Can we evaluate the probability that C is infected given all the other information? So it's basically a probabilistic question. And as I come to, given the assumptions we make, we actually have the best possible answer. So the problem is not the methodology, but the assumptions. So I'll come to the limitations already before coming to the talk. we know that COVID is airborne, and not just airborne. If you talk about the discourse last year, people were talking about, even now people talk about keeping 2-meter distance because it comes in droplets which fall as projectiles over this distance. And so you have these pictures of a person with a mouth and some stuff falling like that at 2 meters away. Yes, but no, because you also have this fine droplets aerosols, which people now acknowledge are probably the dominant cause of spread, especially indoors. In open air, they disperse, and there are no or very few documented super spreading events in the open air. And the ones that we can think of, probably you can explain it away by it being a multi-day event. So people are also cooped up indoors, in the closed air. But essentially the belief is indoors is much more risky than outdoors. And the main thing is that stale air can stay infectious after you leave because it's aerosol, it hangs around, it goes through the HVAC system. So all this was not on our mind when we did this, and it is not in the methodology here. So I'll give some thoughts at the end of the talk on how to deal with all this. But within our limitations of basically ignoring that, what we do in the preprint is we have 2 probabilistic frameworks, which one of them is essentially exact, and the other is a kind of coarse-grained thing, which would also be exact if you do it at a large enough scale. And then we have a simulation mechanism to test out this framework, which validates what we're doing quite well. So I'll talk about both. What we find is that within our assumptions, what we do is optimal, and that you can't do better. How do we know that? Because we simulate the system many times with the same initial condition. And then we can evaluate the probability at any time that any individual is infected, which is simply the fraction of times in the total number of simulations that the person was, and we converge to that value. So basically, it is in some sense a correct answer. And this and we strongly outperform assessment using direct contacts only, meaning including second order contacts definitely helps. And we find that it is quite robust to substantial loss in contact detection. It's in the manuscript, but I haven't put in the slide here. And if you test and isolate probable individuals, that yields quite substantial flattening of the curve, meaning the pandemic doesn't expand to the level it would without these measures. I would say this is a little bit, so these are both true in idealized situations. I would not necessarily say they would be true in the real world. But the main thing is that we store everything locally and nothing is sort of shared with a central server except an alert if your probability of being infected crosses a certain threshold. So nobody knows your contacts and where you've been and so on. You don't even need location information at this point. So what do we do? The basic idea is this. Supposing you meet, you are, let's say, not infected and you meet somebody who is infected. You're basically assuming that there is a transmission probability per contact, P sub T. And this is actually related to the infection rate in the SIR model, which I'll come to. And the idea is that if I meet you once and you were infected, then with the probability P sub T, I will be infected. So this is that initially I was definitely uninfected. Now with this probability I'm infected, and vice versa. But if I met somebody who was not definitely infected, B had an infection with the probability P sub B, then now my probability of being infected is P sub B times P sub T. And if we both had a finite probability of being infected, then this is the value. So this is so basically the way to understand this for those who are not well up on probability theory is that I want the probability of not being infected. So this is the probability that I already wasn't infected. And this is the probability that I am still not infected after meeting B. And 1 minus that is the probability that I am now infected. And we do the same update to B's probability. So that's the basic idea for a person-to-person contact. So what we do is we simulate a bunch of individuals this way. Each individual has, this is also the algorithm for the real world. If you were to implement it on a mobile phone, you give each individual a unique ID, which could be the mobile phone. It does not need to be the actual mobile phone number. It could be some one-way hashed version of it. You initialize the infection probabilities based on prior knowledge or self-reporting, meaning mostly it might be 0 at the beginning of a pandemic. But some people might self-report symptoms and then you might give them a non-zero value. Or some people might have been tested positive recently and then the app would make it a 1. Each individual's app maintains a list of all recent contacts. So I, on my phone, know, well, even I don't know, but my phone knows who I have met in the last 14 days. And also, it knows the meeting times for each contact when I met them. And if it's longer than 14 days ago, I drop it from my contact because probably, even if they gave it to me, the time has elapsed, I'm probably no longer infectious. So then at each meeting of A and B, the apps exchange the current values of PA and PB. So my Bluetooth will tell your Bluetooth that I am infected with probability P sub A and vice versa. And we each update our probabilities to a new value. And all this stays on the phone and the holder of the phone need not even know about it. So the key thing is what happens if somebody tests positive. So I had some probability P sub A, but now I've been tested and there are very few false positives. So I just update this to 1. Now I have already met a bunch of people. So for every person B that I met, I need to update their probability. Their probability was done assuming that I had a probability P sub A, but what I have is a probability 1. So I need to update it with this. Now their probability has changed. They in turn need to update whoever they met. And you need to propagate this update forward. And if you do this, it could turn out that C met D and then D met A, and you could get into a cycle. So you avoid that using some ignored list. Every time you update contacts, you also say who you should not bother to update because they're already updated. So this looks a bit complicated. It is doable, but it turns out first of all, you need some kind of server to mediate these updates. And secondly, it turns out we do quite well even without this, just by updating immediate contacts. So the key thing we are doing here that is different from what a naive immediate contact is that we are updating contacts using this formula, which is technically correct formula within this assumption that P sub T is constant and so on. So this is the transmission of infection part, but we also have recovery, right? So infectious individuals slowly recover in the SCIR model that's given by a rate constant K sub R. Related to that, we have P sub R, which is the recovery probability for each individual, which it's actually essentially the same thing. So at each node, we multiply, so the epoch here is a time cycle. I'll come to that in the simulation. Each node's risk factor is multiplied by this so that it goes slowly towards 0. And then a recovered individual was marked immune, which in the real world, immunity would wear off. It could also be removed, meaning they might have died. Either way, it's the same thing. They no longer play a part. Yeah. So in fact, Jonathan had mentioned immunity via either disease or vaccine. In India, we are seeing that probability immunity from the first wave has worn off because serological studies suggested more than 50% of people were infected in some cities, but they're seeing raging pandemics right now. Nobody fully understands why. It could be a combination of immunity wearing off and immune escape at a new variant. It's not established. So with that, let's come on to the SCIR compartmental model, which I think all of you already know. So I'll just quickly go through it. This is what Jonathan also called a well-mixed model, meaning you have large population and everybody's talking to everybody else. And there is some number of individuals that are susceptible, which is initially all of them almost, and some who are exposed, but not yet infectious, some who are infectious, and some who are removed, which means recovered or dead. And you have these three rate constants, K sub I, K sub E, K sub R, which controls how these compartments move among each other. We can relate these rate constants and things to the parameters in the previous. Okay, so I'll just come to that part. What do we do to simulate on a network? So we basically have agents who are nodes on a fixed network. That means that so the assumption we're making is that I know a certain number of people and I might meet them. I'm not very likely to meet anybody else. This could be changed in the code, but it's a little bit, it's much simpler to do it this way and probably not a big issue. So the network consists of individuals who are nodes, and the links indicate all possible contacts. If I know 100 people, then these are the 100 people I might possibly meet. Link weights indicate the probability of contact when sampled, meaning I have agent A here, agent B here, and a link of weight half. That means every time I consider this link, half the time I will say that they met, and the other half I would say they don't meet. And you can then get something like a coordination number, which is the average number of contacts per node. It's just the weighted sum over all the links from the node to other people. Now, initially you mark all individuals, that's all nodes, with ground truth, SC, I, or R. Initially, most of them are S and a few are I. And similarly, you mark the risk probability, the thing that we calculate, to 1 for I because we know they are infected, and 0 for everybody else. Or it could be some small number in the real world, but in the simulation, we pick 0. Each pass, you sample each link once, and you update the probability at each contact. So I have a network with links, and during each pass, I sample each of these links exactly once. And I either pick the link or don't pick the link with the probability proportional to the weight. If I pick the link, it meant those people contacted each other. And if they contact, we update the probability exactly as I described earlier. But we also update the ground truth, meaning are they really susceptible, infectious, recovered, in order to compare with the ground truth, compare the probabilistic thing with the ground truth. We update this probabilistically using these rates. Here's an example of how it might go. This is the network. 1 is the only person who's initially infected, and so probability 1. And I sample this link, and this person then gets infected with the probability 0.1 from the formula previously. Now, this person has met this person, and this person has met this person in the next epoch. So these two get updated, and so on. So at each step, I am updating not just the person I met, but also their contacts. Okay, this is the last step where, in fact, I end up testing this person, and this person tests positive. So from 0.2, this person has jumped to 1. That means all this person's contacts also get updated using the formula I described earlier. So that's the simulation. We update the risk factor by the previous formula. Just as a point of comparison, we update something which we call the naive oracle probability, which is basically we know who's really susceptible and who's really infectious. And so we update the probability using this if there was a contact between a truly susceptible and a truly infectious person. Then this is the formula we use. And we can derive all these parameters from the SCIR model. Basically, R0 is the basic reproduction number, which we'll come to. In the simulation, we have these parameters. MD is the number of epochs that constitute 1 day. So as I said, an epoch is just a full sweep, and you could have that being a day, or you could have multiple sweeps in a day. D sub B is the average exposure time, and D sub R is the average recovery time. Then the probability of converting from infectious to exposed is this, and the probability of converting from exposed to recovered is this. And from the SCIR parameters, so I think I'll skip this slide, but it's there in the manuscript if you're interested. Essentially, you can calculate P sub T using R naught, P sub R, and something which is N sub C, which is the average number of contacts is what was there in a previous slide, average number of contacts per link. So I mentioned a little earlier that we validate this by simulating a large number of times, but then we realized we can actually sort of simulate, we can do a sort of simulation of that kind where every individual actually has her own results for just for that individual for the entire simulation. So we initialize something called a frequency vector V, which contains a possible ground truth SEI or R. And the ith element in this frequency vector is the current state of node. And so we are simulating an ensemble of, let's say, 1,000 simulations. And the 56th element of this would be in simulation number 56. Am I susceptible, exposed, infectious, or removed? You update this deterministically exactly as we update the unknown true status in the simulation. But this is a vector of values, and the fraction of i's in this vector would be the probability that you're infectious, similarly for S, E, or R. So those are the two things we do. And now we're on to the results part. So the first point is that, as I said, we look at a complicated network, which indicates who are the possible contacts each node might have. The simplest network is a complete network where every node is connected to everybody else with weight 1. That means that at each epoch, I will sample everybody. I will make everyone meet everybody else for sure. And this is basically the same as the SIR model. It's a well-mixed model. And if you look at the quantitative numbers, so the dotted lines are from the differential equations earlier for an SIR model with R0 basically with the parameters derived from, well, the parameters are basically the same. It agrees extremely well with N being the actual population size. So R0 was derived from N, right, in this equation. So you use N as the actual population size, it agrees very well. But with any network that is not a complete network, it does not agree well with N. It does not agree well even with any effective N, as people might argue. So this is actually well known to people who simulate this, but I think not to the general public. So what we use...
Requested 5-minute warning.
Thank you very much. So we have a family unit of like 3 to 5 people, or I think 2 to 5 people, who are all fully connected with weight 1. So I will meet my wife and kids every day, and they will meet each other every day. On top of that, I have a few spreaders. 1% of my nodes are heavily linked with lots of people. So these might be people like shop attendants and receptionists and doctors and so on. So, and then we add links by the Barsi Albert, because we all meet other people outside of our home. And the number of people we meet is proportional to our, so we add links with a probability proportional to the current coordination number. I apologize if these things are slow. I made these slides in like a day and a half, and I've spoken on this before. We put in all these kinds of links. The idea is to simulate a real society somewhat realistically. And it turns out that if you model an SEIR type model on this kind of a realistic network, you have to tweak N, the effective population number, to get any kind of agreement. This is with 10,000 nodes, this is with 100,000 nodes. The effective N is nowhere near 10,000 or 100,000. It's about 4,000 here, and it's about 23,000 here. But even then, it agrees in some patches. Susceptible and recovered agree quite well. But the exposed and infectious curves disagree quite sharply. So the message is the well-mixed model is not a good representation of society if you want to get quantitative. Okay, so now we have 3 ways to calculate the risk of an individual: this risk factor and the frequency vector, which should the frequency vector is essentially the same as lots and lots of simulations. So what we do, and the third one is the naive oracle, which is basically, I know the truth, but I'm updating the probability using only first order contacts. And I'm comparing the results here with what I would get over L simulations. Cosine deviation is basically x dot y divided by mod x mod y, and Pearson correlation is, so as you can see, as L, the size of your frequency vector or the size of your number of simulations increases, the agreement between the risk factor that we calculated probabilistically and the frequency vector is extremely high. Whereas the naive oracle does not agree that well, especially if you look at the Pearson value. If you look at an ROC curve, true positive versus false positive, again, I'm sorry for the size of this slide, but blue is our probabilistic algorithm, green is the naive oracle, and red is random. For the same 100,000 node network at 3 different epochs, 200 where 2,000 out of 100,000, 2% of the population was infected, 6% was infected, and more than 10% were infected. For some reason, the naive oracle actually does very badly compared to even a random model. Random means you randomly decide whether somebody is infected or not. And the blue line is consistently better than random. Maybe not that much better. That might be because there are a lot of true negatives in these scenarios. So if you look at precision recall, the blue curve seems to do much better than the rest. This we are comparing also the frequency vector. And as you can see, as you increase this is frequency vector of length 10, length 100, and length 1000. As you increase the length of the frequency vector line essentially coincides with our risk factor line. So basically, our probabilistic calculation based on what a single person's mobile phone knows agrees with a large-scale simulation. That's the message here. So that's more or less the end of my talk, with the caveats that I mentioned earlier. We know that spread is much more indoors. One way to look at that is P sub T is much higher if you're indoors. It also depends on things like, are you wearing a mask, which the app doesn't know. And we know that the pathogen can linger in indoor air for hours, which means I leave the room and you come in half an hour later, the app will not detect that contact. Is there any way we can deal with this to take account of how COVID really behaves? For example, can the app figure out that the person is usually masked by seeing if repeated contacts don't end up with an infection? So this assumes regular testing, I guess, but somehow can you assess based on the changes in P sub T that an individual is safe and lower that P sub T accordingly? Can you learn indoor-outdoor status without turning on location information? Even if you turn on location information, it makes a difference whether it's a huge, well-ventilated room or a small claustrophobic room. Can you learn something about it by aggregating contact information? And if you know that 100 people have been in this room in the last 2 hours, and one person was infected at the beginning of the hour, but people at the end of the hour also got infected, then you know that this is that kind of a place. Can you do something like that? How would you do all this by keeping privacy in mind? Because this was kind of important to us when designing this, that we don't want to share information with the government server beyond the bare minimum possible. Right, so that's the end of my talk. I'd like to thank the collaborators again, and thank you for calling me. And I'm very much welcome ideas on what we can do with this at this point.
Thanks so much. And particularly your last slide is very relevant to what PathCheck is actually trying to do with the apps and privacy. So I'm sure a lot of people will have thoughts or questions on that. No, Rohan, do you want to maybe facilitate some of the Q&A?
Yeah, definitely. So I think while, okay, so folks, please.
Maybe we can stop screen sharing.
Yeah.
Yes, I'm sorry.
No, you're.
Yeah, feel free to type in the questions in the chat or ask it out loud as well. So we have a question from Pawan. Is there a way to account for change in behavior of individuals due to public announcement, awareness, activities, etc.? So,
Sorry. That was a question for me, I guess. It's a good question. And in fact, we had some such, I can't remember whether it was in the manuscript, but yes, if you have a lockdown, then you could simulate that by reducing the contact probabilities drastically. So within household would stay at 1, but external in the network, the weights of the nodes would be reduced so that you would sample them less often. So in terms of masking, if you believe that people are mostly masking and keeping distance, you could reduce P sub T. But these are things that can you do it at the level of an individual mobile phone? Would you do it at the level of a central server that everybody's values go down? These are questions that I don't have a good answer to.
Maybe we can also throw that one to Professor Berman as well, because I think that is actually applicable to both of you.
Yeah.
Is there a way to account for behavior of individuals due to public announcements, awareness activities? So I think with regard to assessing the reach or the degree of vaccination that's necessary to end endemic transmission, I think that I think that the best thing we can do at this point is work based on numbers of actually vaccinated people and assume the highest estimated R0. And that's why we're seeing numbers from people like Dr. Fauci and people in the CDC saying we might need 85% because they're assuming a worst case scenario, because people aren't going to be willing to keep up lockdown behaviors forever. Eventually people are going to go outside and will reach those levels of mixing that people had prior to the pandemic.
Thanks. I think there's a question in the chat.
Yeah. So there's another question, and this is again for Rahul. So it's from Dr. Meeta. The green ROC curve is pretty bad. My understanding was this is what your typical contact tracing app actually does, and it is worse than random. I must have misunderstood something or not.
So it is worse than random. It is bad. It is not what your contact tracing app does. It should, we would think, be better because it actually knows whether the people being contacted are really infected or not. So if I meet you and within this simulation, I know that I'm infected and you're not, then it increases your probability of being infected by P sub T. So that's why we call it a naive oracle. Why it is so bad is not clear to me. And yes, we should be thinking of maybe remove the oracle part of it. And I think we did do that, and it was also not very, I mean, it was also quite bad. Meaning you update just the immediate contact, but okay, so what a naive contact tracing app does, it doesn't actually assign a probability. It instead, the public health authorities basically find the contacts and go to their home and test them and trace them, isolate them, whatever. So it's kind of done manually, and it's only really workable at the early stages of pandemic. Once you get to millions of people infected, you just can't do it. Yeah, that was it.
Definitely. I have a question for Professor Berman. Just from a real world perspective for right now, what do you think would be some strategies that would be most effective to promote people getting vaccinated? I know you talked about under-vaccinated people, so clearly there are strategies to identify people that don't have access or have other barriers, but are there other interventions that you can think of that would be helpful?
So most right now, the biggest problem is not anti-vaxxers, it's under-vaccinated. So those are supply chain for vaccine manufacture. And that's kind of out of our hands, I think. That is distribution. So in the US, are the logistics of getting everyone vaccinated, there's actually a lot of vaccination going on right now, about 3 million people a day, which I think is impressive. But eventually, steps are going to need to be taken to get that out to people who maybe have to drive a long distance but don't have a car, or for whatever reason are unable to get to a pharmacy and so forth. So I think that's the most important thing. Another important thing we should be doing, I think, is tailoring messaging to populations. So there's a lot of messaging that's written by people like me, that because it's written by people like me, target people like me and doesn't speak to other people who aren't like me. So we need to have a strategy where I think local knowledge needs to be brought to the forefront of messaging campaigns. There have been some very effective vaccination campaigns centered around working with local religious leaders, with imams and rabbis and so forth, and getting them to speak to their congregation, having trusted people in various communities get publicly vaccinated. All of that goes a long way toward those nudges toward vaccination. And then I think just on the individual level, just being clear in our position pro-vaccination. Yeah.
Great. So I believe there's one more question for you, Professor Jonathan. It's again from Dr. Ninja. It's about, is there any long-term data on anti-vaccine sentiment? I have some impression about long-term attitude towards science, not very scientifically obtained. And I wonder how it matches.
Yeah, so people have done tracking data over time, especially over the last 20 years. And there hasn't in that period, except for the pandemic, been a huge growth. And the pandemic's kind of changed everything, probably largely because of that political polarization. That seemed to give the anti-vaccine movements organized elements something they needed, which was an audience. And it gave anti-lockdown, anti-mask protesters a set of tactics to use. So they both benefited in that, I guess. So if you were to graph it, it would be something like this and then shoot up over the last year or so. And then someone else asked, are door-to-door vaccinations feasible? In some cases, yes. So this is the biggest issue. There is the cold chain problem, where depending on the vaccine, you have to keep it temperature stable. And so there are a variety of solutions to that, but it does get trickier when you have to go door to door. There've been a lot of talk about doing trucks, buses, mobile clinics too.
Yeah, I know we have some people at PathCheck that are some medical students and MD PhD students that are going out into communities, and I don't know. I think that's a really good idea to have med students go out and maybe interact with local leaders and join forces, because that's kind of an underutilized, I think, group of people that have the time and also the know-how to do that kind of thing.
Our med students have been going out and doing that. I would have, in the past, I would have assumed that med students were at some point trained to do things like intramuscular injections, but not in the first 2 years. So we've been having training clinics for how to give vaccines and then sending them out on a mobile clinic to help vaccinate local people.
And I just had a question for Dr. Siddharthan. So I was listening to your talk, and I'm super interested in this personal risk calculator for people that you're talking about, and I think it's in PathCheck is talking about using this Bluetooth technology, right, to notify who you've been near and if they've been exposed. I was wondering if, you know, an earlier version of that, like, could rely on population probabilities instead of actually Bluetooth as the first step. So, you know, what are the chances that you're going to run into someone with COVID in your community based on active case levels, for instance? I wonder if you have thoughts on that.
So I guess that would be something like, so if you're talking about an individual level, given the COVID case levels, what are the chances that I would run into somebody with COVID? Yeah, that is a good question. I haven't thought about that. I guess what I described really works at the very early stage of a pandemic, where the case levels are actually very low. And I had shown like 2% and so on. But in fact, I think it would be useful much, much lower than that. And I guess it would be doable, but essentially what you're doing then is averaging out. So I live in an area where maybe 1% of people have a COVID infection. And so maybe I could calculate that I have met 10 people today, and therefore my chances of having picked up the infection is this. So that's an easy calculation. Is it useful? I'm not, maybe it's worth doing. Thanks for the idea. And I'd be happy to discuss further. And by the way, the code is there on GitHub. It's written in the Julia language, which I think also has an MIT connection. But
amazing. Would you mind just putting that GitHub link in the chat? I would love to check it out. I don't know Julia.
I'll just do that. Okay, I'll take a look.
I don't know Julia, but I'm sure someone at PathCheck does. So. Yeah.
I haven't updated it in a year, so but here it is.
Yeah, what do you think? What do you think some of the momentum and barriers are with this kind of strategy for risk calculation that you've discussed, particularly in your experience with your group?
I think, well, the barrier in India is that by the time we wrote this up, it was already done by the government, and we actually shared it with them, and they said, thanks for the interest, and somebody will be in touch. But I think they probably decided it's not worth the effort. I don't think contact tracing has been, using mobile apps has been a huge success anywhere in the world, at least for this pandemic. Doesn't mean it couldn't be in the future. It could be a useful early warning system. But for COVID, I now feel that it's kind of an oversimplified model. So it's a useful theoretical exercise, but will it be actually useful in deployment? Maybe, but you all have much more real world experience than I do. So if you think there are useful ideas there, we could take it forward. So I see there is another question for Jonathan in the chat, and I also have a couple of questions for Jonathan, if I may.
Yeah. So I think Professor Jonathan answered the door-to-door vaccination feasibility.
That's right. Yeah. Okay.
So yeah, I guess
go ahead. Okay. So yeah, mine is again about, well, it's about the rare events thing, and how do you persuade people that a few bad anecdotes. So for example, there is this whole, right at the beginning of the Indian vaccination thing, the headlines were full of how many people have died the day after getting vaccinated. And the numbers were something like 8 in the first week, went up to 20 in the third week. But if you look at how many were vaccinated, it was a few million. And so this is actually less than the death rate you would expect in a population that size. At least it was not out of the ordinary. How do you communicate that to people? And then there's the AstraZeneca and now Johnson & Johnson clotting issue. It seems clear that there is likely a link if you look at this specific syndrome, but it is so rare that individuals should not worry about it. They should worry more about driving to the vaccination center and getting in an accident on the way. How do you communicate that kind of thing? And especially, this is the third item. Just last week, a very well-known actor in my city, Chennai, died the day after getting vaccinated. And then the postmortem said one of his arteries was 100% blocked, and it was not related to the vaccine. But others are suggesting it could be an example of the clotting syndrome, which blocked his artery. How do you, but this has caused vaccine skepticism, which was already pretty rampant. How would you deal with rare events like this which get amplified in the media?
Yeah, so that's something I've been looking at lately. I was looking at the VAERS data, which is there's kind of three mechanisms for tracking potential vaccine side effects in the US, 3 or 4, and one of them is this vaccine adverse events reporting system. And there's a viral video going around where an anti-vaxxer reads off lists of symptoms that have been entered into this VAERS system, because this is public data. And they suggest that other anti-vaxxers go online and muddy the data by uploading false reports. So I've been looking at that both from a descriptive perspective of, well, how have the reports changed over time? And so you can chart how often these reports include the word, say, autism over time. And in 2001, it was almost it's a little more than 0.5% to now when it's close to 0%. And then words like death, which have been fairly level at close to 0 and then spiked in this year. And so they're asking, well, why has it spiked? And I think the obvious reason is that we used to be vaccinating children who didn't die usually within the 2 weeks after vaccination at their 1 year checkup. And now we're vaccinating a lot of older people who are more likely to die in that 2 week window. So I think we have to do a better job messaging about how many people we would expect at that age range to die shortly after vaccination. And we have to do a better job just talking about how we monitor vaccine safety. And that gets into your other question about Johnson & Johnson, AstraZeneca. I agree. It looks like there may be some connection there. That is a rare type of blood clot, and you wouldn't expect that many of that type of blood clot. But it's also a very, very small number of people in absolute numbers. And the absolute number of people who are going to be harmed by these pauses and by the doubt that creates are much larger. So I think the regulatory bodies have maybe made a mistake in overcorrecting for vaccine hesitancy by being almost too cautious about events that may be the result of the treatment. When we have treatments on the market, a lot of people pointed out that birth control carries a fairly large risk of blood clots, which is still a small risk in absolute numbers, but much larger than this. And we hardly ever talk about it. So I think that there might be a strong argument in the future for changing the way this kind of event is handled, so that something with a relatively small amount of absolute risk doesn't trigger a pause on the vaccination program. And yeah, so I think that they're going to pick out deaths and attribute them to vaccination no matter what. And we just have to be clear in pointing out that this is a matter of probability. Some number of people are going to die in the 2 weeks or month or year after they're vaccinated. And to say that it's an effect of the vaccine, we need science demonstrating causality.
I guess my question was, yes, I mean, so what you said in terms of risks and, is what we all understand. How do we communicate it to a nervous public? But I guess that's a challenge everybody's facing. And
Yeah, I
is
mean,
there something striking one can say to them that is as striking as the fact that an actor died the day after getting a vaccine?
I think we just have to say it, because
Right.
most of the time, no one
Yeah.
is saying that to them at all. And if someone is just honest with them and say, yeah, this person died, but it's people die, it's not always causally linked, then that at least nudges them back a little bit in the other direction. And I mean, you can come up with all kinds of examples of coincidences to demonstrate that coincidence exists. But I think I think the most important thing is to actually say that to people.
Thanks.
Yeah, I mean, I think it's getting the message out and also public trust, right? People have to trust the messenger. So that's another big issue. If they don't.
And the other big issue is people don't trust the pharma companies, and I think they have good reason not to. So that is a huge issue here.
Yeah, and I think that's another area where there's a lot of failure in the way we just talk about it, because it's either the big pharma is evil and they're plotting against us or whatever, or we say, well, they're not doing anything wrong. And the truth is probably somewhere in the middle. They're big companies, they have a profit motive. Their interest is not always our interest, but also that's why we have regulators to look into vaccine safety and study this. So yes. I think just being that little bit of honest in our communications goes a long way toward building trust.
Yeah, and so I run a nonprofit, and I actually talk to people on the internet for my science advocacy nonprofit. And part of that is, I think, just being available for people. Scientists are so busy, but there's just this like disconnect between scientists actually talking to the public. And I think having real conversations humanizes it and builds trust. Because I think we're siloed in these universities a lot of the time, and I think people are pretty open to this kind of messaging if you actually talk to them, but that's a hard ask, right? So
that's a good point. Yes.
You know who's really siloed are farmers.
Why is that?
There's a pun. That's right.
Oh,
Farmers
okay,
have silos. Yeah. Yeah.
Okay.
I don't know. I mean, I guess if there aren't any other questions, Rohan, do you think we should wrap up here? What is your feeling?
Yeah, I guess so, given that I've stretched a bit longer than the actual time. So I'll stop the recording right now. And before that, thanks a lot, Professor Rahul Siddharthan and Professor Jonathan Berman. It was really insightful talk, and definitely for everyone for the questions. It was a really engaging discussion. So thanks for spending your time over here.
Thank you.
Yeah, thank you very much.
Thanks so much.